And the title of my talk is Waiting for 10. I will put a bit of a disclaimer. I'm an adult nurse, so we don't see a whole lot of inhibitors. I have no disclosures. So the objectives of the talk today are to really quickly touch on inhibitor management, define immune tolerance induction, and do a quick overview of protocols that exist, where this waiting for 10 BU came from, and a few other considerations. So as Chris mentioned, before we continue, the focus is on inhibitors in hemophilia A, so factor VIII, severe factor VIII, untreated patients, and newly diagnosed. In adults, we don't see a lot of inhibitors in our center. They're usually treated and eradicated by the time they get to us. As Chris said, inhibitors in hemophilia B are rare, and they have considerations that complicate treatment decisions, and it's mostly severes. So there are two objectives in inhibitor management. The ultimate goal is to eradicate the inhibitor. Why? Well, because as long as the inhibitor is present, the risk of bleeding remains high, and effective treatments to stop bleeding are limited. Eradication depends, to a certain extent, on the titer of the inhibitor. As long as you avoid continued exposure to factor VIII, oftentimes you can hold prophylaxis and see what the low titer inhibitor does. If it's a high titer and these don't disappear, then ITI is a consideration. So second, part of managing the inhibitor is considering how to treat any bleeding that occurs, as the neutralizing factor VIII antibody will make any factor VIII concentrate ineffective. In high responders, bypassing agents are usually used, so recombinant 7A or APCC. These are associated with higher costs and increased risks, such as thrombosis, and can have variable effectiveness in controlling the bleeding. There is no reliable lab test to measure bypassing agent effectiveness. You can't measure the factor VIII level, as it will always be less than the 1% as long as the inhibitor is present. So what is ITI? There are a couple different protocols and guidelines. Really quickly, there's the BON or the BON type, which is high-dose factor VIII, so 100 to 200 units per kilo per day. This is more costly than lower dose regimens. There's a greater need for central venous lines. It is associated with fewer bleeds during ITI, and you may achieve tolerance faster than lower dose regimens. It is probably more successful than low-dose regimens in poor-risk patients. And the low-dose regimens that we're talking about are factor VIII, so 25 to 50 IU per kilo daily to 3 times weekly. These low-dose regimens are less costly. There's less need for central venous line access. Can be associated with more bleeds during ITI and may be slower to induce tolerance. But the ultimate success rate may be similar to high-dose regimens. Then there's the Malmo type, so reserved for failure of the BON type regimens usually. This is high-dose factor VIII with IVIG. You get immunoadsorption, which is not readily available, and in younger patients might be difficult due to venous access issues, and it includes cyclophosphamide. So really, there's no one correct protocol or guideline. It is dependent on the resources available. And if you're in a resource-poor area of the world, you may want to save the high-dose regimens for those patients that continue to present with severe bleeding. And then the title of the talk, Waiting for 10, or When to Start ITI. These guidelines are based on the data gathered from registries that say that better success with ITI is when your patient is younger. The peak historical titer is less than 200 Bethesda units, and the inhibitor titer pre-ITI start is less than 10 Bethesda units. In children, you want to preserve joints. In adults, there's a bit of a different story because they're going to require surgeries. And you want to be able to use factor VIII concentrate if you need to. It can take up to 6 months for the inhibitor to drop below 10. And if it's still greater than 10, 1 to 2 years after it was first detected, then you can start ITI according to these guidelines. Similarly, if an inhibitor develops in the presence of life-threatening bleeding, like an intracranial hemorrhage, you would probably want to start ITI as soon as possible to try to get rid of that inhibitor and treat the bleeding. So I guess the question is, do you treat the number or do you treat the patient? It does depend on the resources that are available to you. In resource-poor countries, it may make sense to wait until the inhibitor reaches 10, as long as there's no significant bleeding. Also depends on the patient. So again, this just kind of summarizes why wait for the 10. When it's less than 10, there seems to be a higher success rate for eradication. It takes less time to reach tolerization. And this actually has the advantage of reducing the burden on the family of the patient or the caregiver. Also the hospital as well, and hospital-associated costs with decreased visits. Reduces the risk of joint disease and of difficult bleeding. Waiting, actually, while you're waiting to get to less than 10, may put a patient at increased risk of difficult-to-manage bleeds. This, in turn, negatively impacts quality of life, joint health, and healthcare costs. It's quite expensive to use bypassing agents for treatment and for prophy, if you're going to do that. And they come with increased risk of thrombosis when compared to factor concentrate. And there is some evidence to say that they may not be as effective in reducing joint damage. So just other considerations. In factor IX, really quickly, ITI is less successful. It is associated with high risk of adverse events such as anaphylaxis, nephrotic syndrome, and there's really not a lot of information about them. For us in the adult world, there's 3 adult populations with inhibitors. First are the patients with a history of an inhibitor. Maybe they never cleared. Now it comes and goes. We do have one patient at our center where the inhibitor kind of comes and goes every couple of years. Locally at our center, we have used rituximab to try to eradicate that inhibitor with varying success. The second population in adults are the mild or moderate factor VIII patients, where the mechanism for development of inhibitors in this group is different. The kinetics are different. And in some cases, the inhibitors disappear spontaneously, but there is that risk of amnestic response with further factor VIII exposure. And we do have one patient at our clinic where this is the case. He ended up having a colonoscopy, got factor VIII, and boom, we've got an inhibitor back. The other population are the previously treated patients with many exposure days who develop an inhibitor all of a sudden, and we really aren't sure why. Again, locally at our clinic, we do have one person that did this. He's in his mid-60s, so tons and tons of exposure days on prophylaxis. All of a sudden had an inhibitor found on routine blood work. It was a low-titer inhibitor. We actually put him on higher dose ITI, and it disappeared within about a month. Thank you.